Welcome everyone. I would like to present my PhD topic, which is physical activity in inflammatory bowel disease. I'm Emese Kasznár. I work at National Pediatric Institute as a pediatric resident, and my vision is to improve the management and quality of life of IBD patients. And for this, my mission is to encourage IBD patients to exercise more to reduce their disease burden. I have three ongoing projects which are investigating the different aspects of physical activities in inflammatory bowel disease. The first one will compare the physical activity between inflammatory bowel disease patients and healthy controls. IBD's prevalence in 2019 was 4.9 million worldwide, and we know that its incidence is increasing over the years. Why is it important? It is an incurable disease which can affect children. 1/4 of the IBD population are children. And because it's a lifelong disease and it's incurable, it is important to find non-pharmaceutical ways to improve the children's and the patient's quality of life. It is a relapsing-remitting disease, which means patients in remission have fewer or no symptoms at all. Some data suggest that even in remission, they have reduced physical activity. And we know that reduced physical activity can lead to many other chronic illnesses, such as metabolic syndrome, osteoporosis, and sarcopenia. Therefore, we raise the question, do patients with inflammatory bowel disease exhibit lower levels of physical activity compared to healthy controls? We had two primary outcomes, metabolic equivalent of task minutes and time spent in moderate to vigorous physical activity. And also we had many secondary outcomes as well. The clinical implication is reducing the risk of osteoporosis, sarcopenia, and metabolic syndrome by encouraging physical activity in IBD patients. Let's jump to the first figure. It is time spent in moderate to vigorous physical activity. As you can see, we could include more than 200 IBD patients and 171 healthy controls. Here, you can see that we used a mean difference as the measure of effect, and it was statistically decreased in IBD populations. It means that patients with IBD spend less time in moderate to vigorous physical activity, to be precise, 15 minutes less compared to healthy controls. We compared the daily steps as well. As you can see, we made a subgroup analysis based on age groups. And as you can see, even in children, their daily steps are reduced significantly compared to healthy controls. Our third outcome is hand grip strength. As you can see, we included adult and pediatric population as well, more than 1,500 patients, and their overall hand grip strength was decreased significantly compared to healthy controls. The last outcome is metabolic equivalent of task minutes. A MET minute means that 1 minute spent in total stillness, so when you are not moving. When you are walking, it is equivalent to 5 MET minutes, and when you are running, it's around 10. So as you can see in this outcome, we could not show any difference between the two groups. A reason for this could be that they did not measure this metabolic equivalent of task minutes objectively in every study. The first 3 studies, in the Malman, Farsi, and Steele studies measured it with smart watches or accelerometers, which is an objective way, but other studies measured it with questionnaires, which are more subjective. So the strength of our study is that we could analyze some outcomes in different age subgroups and that we could analyze many objective parameters. The limitation is that it was not possible to analyze all data age groups separately, and that the outcomes were reported in a variety of units of measure. The conclusion of our study is that patients with IBD have lower levels of physical activity and muscle strength compared to healthy controls. The implication for practice would be to advise patients to engage in more physical activities, and to the multidisciplinary teams to include physiotherapists as well. And the patient follow-up should include muscle mass and muscle strength measurements. Implication for research is to analyze patients with severe and mild disease activity separately, and to analyze patients based on their disease duration as well. Here you can see the status of my first project. Currently, I submitted it to GUT, but it was yesterday, so there is no progress in that so far. Let's jump to the second one. It is investigating the disease activity and quality of life before and after exercise intervention in inflammatory bowel disease. As I mentioned before and showed you, IBD patients tend to have decreased physical activity and muscle mass as well. They can also suffer from anxiety and depression. In 2022, there was a meta-analysis conducted in adult IBD population, which investigated the effect of physical activity. They saw a positive effect in all the overall activity, the bone mineral density, and their mood as well. So we raised the question, what is the effect of physical activity on the patient level, and does exercise intervention affect disease activity and quality of life of patients with IBD? We use the PICO framework. The intervention could be any structured physical activity, and we compared the change to the baseline measurements. Our primary outcomes were disease activity and quality of life, and we also had many secondary outcomes. Our clinical implication would be the same, to encourage patients to do more exercises. Here you can see the quality of life forest plot. Quality of life is a measure which have usually 4 subscales: emotional, systemic, social subscales, and I included the overall plot here because you can see that we used standardized mean difference as a measure of effect, and it was a moderate effect size, but on the patient's level it means that they could sleep through the night, or they had fewer stools per day, so they could improve their quality of life significantly. Here you can see the change in Crohn's disease activity indexes. As you can see, we included children and adult population as well, but in the children population there was not enough data, only in the adults to make a subgroup analysis. And as you can see, there was a non-significant decrease in disease activity scores. The reason for this could be that, as you can see, I added a column of the disease activities, and not every study included only patients who were in remission, but some of them included patients who had mild or moderate disease activity as well. And when they are in remission, they can have a score of 0, which did not make a big room for improvement. Here you can see the change in ulcerative colitis disease activity scores, and the same problem arose here as well, that the studies included patients who were in already remission, and only a few included patients who were in moderate or mild disease activities. Although it seems to be significantly statistically significant, the confidence interval reaches the 0 effect line, but we find it clinically relevant. Here you can see the impact of physical exercise on hand grip strength. As you can see, we could see an improvement in the muscle strength, which they measured with the dynamometer, but it was not statistically non-significant. So in conclusion, the strength of our study, that we compared the changes to the baseline measurements to see the effect of structured physical exercises on the patient's levels. And we could analyze IBD patients according to their disease or their age separately in some cases. The limitations that the heterogeneity of the interventions, and it was not possible to analyze the data in every outcome age group separately. So the conclusion is that regular physical activity improves quality of life, and there is also a tendency for disease activity scores to decrease, even in patients who are already in remission. The implication for research would be to include patients with active disease as well, and the further research needs to find the most effective physical activity type. Here's the current status of my manuscript. Currently, it is at the Journal of Cachexia, Sarcopenia, and Muscle, and we are waiting for the response since January. So in conclusion, I have 3 projects which are investigating the different aspects of physical activities in inflammatory bowel disease. Some additional activities we published sarcopenia in children with newly diagnosed inflammatory bowel disease. It was a pilot study with a small sample size, and we also investigated the Hungarian pediatric IBD population's hand grip strength and physical activity and compared to the healthy children. And we are currently investigating the dietary habits and ultra-processed food intakes of IBD patients. I would like to close with Carl Sagan's words, somewhere something incredible is waiting to be known. Thank you.
Thank you very much. And then now let's open for discussion. So yes, please.
Hi, congrats on your nice work. In the first presentation or first project, did the studies differentiate between different physical activities for the patients? And if so, what is the most recommended type of sport for people with IBD?
You mean when they compare the IBD population to the healthy controls in the overall physical activities?
Yes.
They did try to differentiate with the MET minutes, who measure the MET minutes, because it's should be an objective way of measuring physical activities. But not every study included it, sadly. And some studies, we had many studies, 45 studies, but some only asked them, do you exercise regularly or not? And it was a yes or no question, so we could not include them in the analysis. So it has a big heterogeneity if they included the physical activity type, and they did not conclude anything on what type of exercise they should do. Some of them did yoga, some of them run. They did not conclude anything.
Okay, thank you.
Thank you.
Then I ask a question because I have the mic. So I have seen that you chose SMD as an effect measure for hand grip strength. And I would like to ask you, what is SMD and why did you choose that for that outcome?
Thank you for your question. It's standardized mean difference, and we wished to use mean difference because it's a strength measurement, so one would think they have the same units, but many studies reported them in a different way, measured them in a different way, which means some added the strength of the dominant hand, some the non-dominant hand. One measured it 3 times and chose the highest value. Some measured it 5 times and chose the average value. So that's why we thought that it would be the most appropriate to standardize these and use standardized mean difference.
Thank you.
Thank you.
Yeah, maybe I will have one. So you're working in the Henba hospital.
Yes.
Do you know the approximate number of kids with IBD who are followed up there?
Who are followed up there. I'm sorry.
That's fine. I just wanted to ask, you know, if you are planning to implement your findings, physical training in your IBD cohort, or do you want to have any analysis on them?
To jump to the third project, which I had no time to explain. First, we wanted to make a protocol for structured physical exercise in children with Crohn's disease who are on exclusive enteral nutrition, but it was not feasible because of the number of patients needed in these studies. So we are planning to do a pilot study so we can estimate the real number needed in this study.
So it's in progress.
Thank you. It's a really interesting study. And for the first topic, you discuss about IBD with the physical activity, but there are 2 types of IBD, which is dramatically different between the consequences regarding the malabsorption, the body composition, and so on. How you can compare Crohn and ulcerative colitis in one manner, because they are really different.
Yeah, thank you for your question. We wanted to analyze them separately, but many of the studies did not report their data separately. So that made our analysis impossible. We wished to.
Not an option. No, not an option for us for this data.
I did.
Maybe
Only a few responded, and it was not enough.
Okay. And also interesting question is about the body composition and the enteral nutrition, which
Yes.
already mentioned with your third topic.
Yeah.
So you can also adjust for this ongoing treatment, who are taking steroid, who are taking just the diet. Do you know any subgroup analysis regarding this in your data? So who are treated with steroid and who are not?
In the
differences between them.
Yes,
Yeah.
when they compare the healthy controls, the physical activity in my first study, you mean?
Or also with your ongoing
It's
study.
on the ongoing. Yes. So in our third project, we wish to include patients who are newly diagnosed. So they are starting the exclusive enteral nutrition, and we would like to start the physical activity training at the same time as the exclusive enteral nutrition is starting. And when we analyzed the physical activity of patients in the meta-analysis, in the intervention part, when they measured the effect of the physical activity, most of the studies included if they used steroids or they were on biologics or what type of therapy they had. But in the healthy, the overall physical activity measurement, they did not specify the treatment most of the times.
In your second topic, you said that there is also a bias with the remission and relapse state, which is very different in the studies. I'm not a statistician, but maybe it's an option to adjust for this PUCI or PCDI, so the disease activity score when you make the comparison, because you have to adjust it because some patients in relapse have very bad access for the physical activity, or it's not an option for maybe this population, and somebody in the remission have a normal life actually.
Yes, we tried to do a subgroup analysis, but there was not enough data, and this adjustment did not occur.
So they're not reporting this, and you cannot ask for it.
Two studies which seem to be outliers. I mean, if you check the plots here, the core and Q study reported that they had patients who relapsed, and they add the Q study at the exact patient characteristics, but the other study did not. So that.
Okay.
So we usually only can use the information that is provided in the article. Other than that, we can ask for it. But if they are not provide this information in the individual patient level, then we cannot adjust really. But that's a mistake on the studies part, because they would have needed to adjust for these, I think.
Last but not least, it's just a remark, because you said for the third topic that you have not enough patients. Of course, it's very easy to understand because Hungary is a small country, and it's very fragmented regarding the IBD care. But your supervisor is the head of this Hungarian National Registry for IBD, so maybe she can also ask for the colleagues to.
We were planning to.
Nationwide, yeah.
But the statistician said that we need thousands of patients.
New patients.
Thousands new patients.
Thousands?
Yes, because we would like to measure, our primary outcome would be the muscle strength. And the muscle strength to change in half a year, it's a small change.
Thousands is too much, because most of the, also not Hungarian, but also from the European articles are just reporting not more than 100 or 200 patients.
Yes.
It's too hard.
Yes.
No, it's not a real option. Thank you.
Thank you.
Thank you very much. I just have some technical questions, not about the meta-analysis, rather with the patient one. So I'm interested that you mentioned children, and you mentioned that you measure the strength of the grip force. So then how you can do that? So what is the device? What is usable for children?
It's the Jammer hydraulic dynamometer that we use at Haimpál Children's Hospital.
But I'm interested of the size, because what you can get on the market is an adult size. So how old are these children in this study?
In these studies, I think above 10. The youngest was 10 years old.
Yeah, because you know the problem that these are too large.
Yeah.
And do you have a special device which is scaled down, or how you do that? Really, that a child can handle this?
In our practice, we do not have. We only include children above 12 years old who are capable of holding it and pressing it down. And it's a big tool, but you can adjust the value, how strong you are. So how hard it is for you to press down this machine.
Yeah, I think that the market should manage that, because it's really an empty spot. You know, it's in the marketplace there is no such device. That's why I was interested that if you have something which is for smaller hands usable. And the other idea is that when you talk about quality of life, but then how do you mean then it is these people feel better because they do some exercise, or really they are doing better, so their body composition is better, the muscle bulk is bigger, they run faster, they have more aerobic capacity. So what do you include in this statement, that quality of life?
So you mean they had already a good quality of life?
So you know, with IBD you can do competitive sports. So there are people who are doing that, and then they manage it. And the question is that now in this study, you expand into so many different molecules, or then you just specify for one thing, for example, muscle mass. And then we know that the muscle mass is affected by the absorption and so on, but still you can overcome this problem with the IBD. You know what I mean?
To be honest, not completely.
Yes, sure. So you see the quality of life, but then you talk about the how strong is the child, which is not quality of life, because then it's one physiological parameter, which should not be confused that if you do yoga, you still feel better, but you are just not stronger. You know what I mean? So these are two very different things. So it's an anatomic process in the muscles, and you can be strong, but you can be still sad and depressed, and your quality of life is not improved. So my question is just that what is exactly the outcome of the second story? So what you measure really?
The quality of life and disease activity index. That was our primary outcomes. I know they are not the hard outcomes as muscle strength.
Just asking that what will be the metrics which pulls together, you know, that what measures you put into the study to say that the quality of life has improved.
And this IBDQ questionnaire, which in measuring the health-related quality of life of IBD patients, it has 4 subscales, which investigating the emotional state, the social state, the systemic symptoms, and the bowel symptoms separately, and then all together we have a score.
Yes, and then you add the physical capabilities too, so the muscle strength as an additional thing. Fine. But do you think that they are two are related? So when people are happier, they are stronger?
They can be. I mean, if they are happier, they move more, they can be stronger, they have more motivation to do something.
Sure. That's good. I think it's a good story. Thank you very much.
Thank you.
Maybe I just add something because you were talking about quality of life. How do you plan to do it? Is it paper-based, or is it based on a device?
The measurement of quality of life?
Yes, the question is.
Well, we would like to do it on a tablet to do not waste as much paper, but we would like to use the same as the paper version, so there's no real difference in that part.
Yeah, mention it because sometimes this is also an option to do an intervention as well. if you have an app, for example, that is, especially when it's about physical activity, that reminds people to do something also, so you can combine the intervention with the question, which is
yeah.
about something like this.
Yes, we were thinking about it to motivate children to do these exercises in a to motivate them in a fun way, and to reach this younger generation. It's the most obvious thing to do is to develop an app, an application where they can follow their exercise regimen and they can check which one they did, or have these videos pre-recorded and put them in the application so they can watch it while they're doing it, and maybe put some fun games in the application as well, so they are motivated to do these exercises at home.